The second topic that I've been asked to present is about describing the value of the ACHQC to private practice. I think this is a very difficult topic. I'm not, sure how the two blend in, but I certainly am in my own private solo practice, and I'm very dedicated to the Quality Collaborative, and will try as best I can to give you some feedback about what I think about this. So in private practice, the solo private practice barriers are numerous. And as a solo practitioner, I'm a bit of a dinosaur. I've evolved this way. I've been mostly in multi-specialty groups to single specialty groups. And ultimately, as my hernia practice evolved, it became most appropriate to be a solo practitioner. So I am a bit of a dinosaur, but I'm a new dinosaur, and I predict my dinosaur species will be increasing as time goes on, because in the end, I think it is the best way to make patients happy. But there are several barriers. Number one, obviously the overhead. You're by yourself, and my overhead is huge. I have a physician assistant, an RN, and three clerical people, the billing software, malpractice, rent. It just goes on and on. So that's one issue. The second issue is the general poor insurance reimbursement, which is everyone is familiar with in our specialty. And then the third aspect as a barrier is that most places are consistent with where I am, where most of the physicians are owned by the hospital or a big multi-specialty group. So rarely are there any solo practitioners or small private practices. I'm the only, general surgeon in my area who is not either employed by the big hospital group or by a multi-specialty group. So the barrier to that is that everybody used to send me hernia cases, and now they only send me their family or complications, and most of my practice is based on word of mouth. So the value of a private solo practice is numerous. The independence is awesome, although I always love being even in a multi-specialty group, and I love being in my single surgical specialty group. You could collaborate and discuss cases, but I can still do this. And the on the business end of it, the independence is unbelievably great. The other thing is that people use this word patient-centric, which is really common these days, and there is no better place to create a patient-centric atmosphere than in a solo private practice, because I'm able to influence people and pick people that will echo what the patients need, which is to be listened to and to be taken care of at a personal level. Another amazing thing about this, my private solo practice, is it's so quiet and peaceful in my office. Growing up in surgery, between being up all night, emergency rooms, also in the office, there was always a lot of commotion with other surgeons and lots of patients and people angry and upset, and vascular lab machines blasting and right next to me. So the quiet and peacefulness in doing one patient at a time, patients are loving it. So what are the solo private practice success strategies? Well, I think one of the most important things that I've done, which has gotten to me where I am and maintains a big part of my volume, is I have such a positive relationship with all the other general surgeons. Basically, there really is no competition. We all are working hard to be good surgeons and take care of patients, and everybody has their own interests. And there is so much work that by maintaining good relationships with other surgeons, I'm there, I teach them things, they teach me things, I send them gallbladders and colon resections, and they send me multiply recurrent ventral hernias. Other strategies with marketing, not so much. Nobody's really looking for a hernia surgeon through an ad in the newspaper. So, I don't do very much marketing. We just do everything we can to maintain quality, which is a big part of getting back to the ACHQC is, transparency and quality. Um, Also, my strategy is this creating this office culture where everybody's on board. People believe in our practice, meaning the staff, and how we do things differently than the hospital. The other important strategy is that I need to have a very high volume in order to pay for that significant overhead and to combat the low reimbursement that is in front of me. But at the same time, I need to be dealing with this high volume in a pleasant and productive way, especially because I want to do this for many more years. So I'm always working to improve my outcomes and my stress level, and by looking at quality measures and entering data and evaluating my data and seeing what works best, my volume increases, my quality of life increases, and other things that are helping is the abundance of education that I pursue and observation of other surgeons. So I am the eternal student. That pretty much is the formula to success. I see many who have kind of learned the way they do it, and they do it the same way all the time. I'm always looking for new options, and clearly the academic world tends to be the creativity of growth in the field of hernia surgery, and I am following that closely. The ACHQC enhances my involvement with the academic world. I am very lucky that all I do is hernia surgery as a private practitioner, so it's a little bit easier to keep up with the ongoing literature than it is for general or vascular surgery. So how did I get here? Well, my father was a prominent nephrologist in the New York metropolitan area. And he had a very good friend, Stanley Berliner, who was one of the original hernia surgeons in the American Hernia Society. Because remember, this field that we're all in now really wasn't like this 20 years ago. When I was a resident in surgery, which was actually on Long Island at State University of New York at Stony Brook, Stanley Berliner had a private practice near my father, and I developed a relationship with him, watching him operate. He used to do beautiful shoulder ice repairs basically all day. So he had a very, kind of gentleman's practice, and even offered me early relationship or at least employment in his practice. But ultimately, even though I thought it was really interesting, I couldn't imagine just becoming a hernia surgeon. So I had to, do much more and become a vascular surgeon. The other thing that influenced me early was a gentleman named Maximo Dezine. He was a very unusual, wonderful bit of a character who was very early in the movement toward hernia specialization. And he taught me a lot also in my early career about hernias and the importance of certain techniques. Ultimately, I got very interested in vascular surgery, and I did a vascular fellowship. And during my vascular fellowship, there's one thing that really struck me, which is all of a sudden I realized I don't have to be the one doing the surgery. So being a good observer of others is what I learned when I was in my fellowship. Like, you know what, I took a step back and watched the professor do the surgery because my hands can move as well as his. I could see what he's seeing, but the watching other people operate really became very important in my career. And then ultimately, my vascular surgery practice, which at one point I was a full-time vascular surgeon, merged with a general and vascular group. And then hernias started to come in front of me, and I had a renewed interest, and then the rest is history. I still, however, to this day, maintain my vascular boards, and it's amazing that I'm still board certified in vascular surgery just by taking the academic tests, and I haven't done a vascular case in probably 12 years. So the other way that the ACHQC is involved in benefiting private practice is the government mandate quality measures, specifically the merit-based incentive payment system, which as a solo practitioner, I kind of have to pay attention to because no one's going to do it for me. The merit-based incentive payment system, otherwise known as MIPS, is something where participating in the ACHQC qualifies me and makes this very easy, because otherwise I don't think I'd want to make the effort, despite the fact that the severity, not just, it's a very small amount of money that you can make extra by participating, but look at this penalty they're proposing, 9% if you don't participate, so, and it's often quite irrelevant, some of these quality measures, but at least the QC is helping me meet these requirements. And marketing with the ACHQC, not so much. But measuring my practice's quality through the QC does increase patient satisfaction and word-of-mouth referrals. Payment or reimbursement, not so much. No insurance company is really paying attention to the quality that's relevant to my practice or most practices. And their payment is based on how little the surgeon will tolerate. So I'm always working on ways to get better so that my practice can emerge beyond the current system of reimbursement. In terms of the benefits of long-term follow-up from the QC, you're understanding your patient satisfaction, your recurrence rate, and the QC allows for ongoing improvement and, again, happy patient referrals. So the QC also, as I discussed earlier, influences my choice of operation and what is best. From good data entry into the QC, I can have a more straightforward decision tree about what is the best operation for a given patient, and that decision could be made faster. So the conversation in my office can be shorter and more effective when I know for sure what is best for somebody. When I speak to patients with this level of confidence, their confidence is higher, and it all makes for good things. So when we look at what we currently use typically for data decision making, it's old data. The question that I ask myself is, the described outcomes from 5 to 20 years ago really apply to what I'm doing today, especially with robotic technology and better lighting and better equipment and better education. And also, didn't the improvement in operating room lighting technology that led to improved pelvic surgery outcomes? We're seeing things like this too. So old data doesn't really apply because we're seeing things so perfectly. Also, didn't laparoscopic surgery improve wound complication outcomes? And that also is something that is not well defined in data before laparoscopic surgery. And here's one that's particularly interesting is, many of us, robotic surgery is absolutely amazing. And doesn't the Da Vinci ultra high definition 3D optics improve our handling of anatomical structures that otherwise could be associated with pain when they're not as well appreciated? So the other issue is patients ask, as we discussed before, what my recurrence rate is, what my level of experience is. I could show these things to them. This is how the QC can help. And then the value is also in my transparency, my link to the academic world, and tools for prediction of the best choice of operation. So the 4 A's for success in private solo practice: availability, affability, ability, and the ACHQC. Thank you very much.